Can we start now?
Yes, sir.
Okay. So here we have a patient who has come to emergency room just now. She's a 25-year-old female. She is having past history of SLE. She was hypertensive throughout her pregnancy. It was well controlled with some tablets. We don't know what exactly it is. Now she presented with ceasing activity 10 minutes back. Bystanders have brought the patient to emergency room. She is in a post-ictal state. Her GCS is low, confused, fully confused, but able to move all the limbs. Her BP is slightly higher now, 160 by 110. You can start managing the case now.
So we are having a patient with a history of PAH. Right now comes with generalized tonic and clonic seizures.
Okay.
So we are thinking in terms of an eclampsia in view of uncontrolled hypertension also.
Okay.
So initially, sir, how's the airway breathing circulation?
Airway breathing circulation is normal, but there are a lot of secretions. Maybe after ceasing activity, they kept the patient on left lateral position and suction was done. Now the patient is stable. Airway breathing is normal. GCS is slightly low because she had post-ictal state confusion, slight altered behavior is there. Circulation, I already told, BP is slightly higher.
So as step 1, we have maintained the airway breathing circulation, everything. So second step should be administration of the magnesium sulfate.
Okay.
So here we follow the Pritchard regimen. Either we can give IM dose of magnesium sulfate or IV dose of magnesium sulfate. If we have a patent cannula, then we can administer 4 gram of 20% magnesium sulfate as the loading dose. Or if we are not getting a cannula, we can administer 10 gram of 50% magnesium sulfate as the loading dose. Can you please connect the cannulas?
IV cannula secure.
Secured. So initially, right now we will give 4 gram of 20% magnesium sulfate. That is 1 ampule contain 2 ml, which is equal to 1 gram magnesium sulfate.
Okay.
So we will take 4 ampules of magnesium sulfate, dilute it in 12 ml NS. Then it comes to 4 gram of 20% solution. Now we can administer the solution.
4 gram of magnesium sulfate, 20% IV given.
Given. Then we will again reassess the patient, airway breathing circulation. We will reassess.
Okay. Now you can watch the heart rate and this one. Now we have already given magnesium sulfate. Now the patient has gone to cardiac arrest. The pulse rate is very low. It is getting low and BP is also getting low. And now she is developing cardiac arrest. We don't know what is the reason.
Monitor is showing asystole. Can you check the pulse? Pulses?
Pulse is currently absent.
So currently we have encountered an obstructive cardiac arrest scenario. So initially, Dr. Shreya, can you displace the uterus to the left side so that aortocaval compression will be avoided? Pretty, can you take care of the airway? Cecil, you can connect the monitor and the defibrillator.
Okay, monitor. Defibrillator is there already.
At the meantime, we will inform the maternal and the pediatric team. Okay. And we'll also consider ECMO in this situation.
Okay, so we have informed the pediatric team and gynecologist. That is done. We are connected, but still the thing is it's a flat line and BP is not recordable.
So at present we are giving compressions and we have displaced the uterus. Can we check the rhythm?
Rhythm.
Leads are connected properly and rhythm is showing asystole. Asystole. So at this point of time, we can administer adrenaline 1 mg 1:1000 dilutions. IV stat can be delivered.
Okay. So third person can give adrenaline. She is doing CPR. Let it continue. So we can give adrenaline. So we have already given adrenaline.
By the meantime, we will assess the causes of the cardiac arrest. Okay. We can assess hypoxia is not there. It can be most probably due to the toxin, that is magnesium sulfate, which we have administered. Okay. That can be one of the cause. Okay. So we will think about administering calcium gluconate 10%, 10 ml over 10 minutes can be administered.
Okay. So calcium gluconate can be given. You can give calcium gluconate.
Calcium gluconate IV given.
IV given 10%, 10 ml given.
At the same time, the time is approaching to 5 minutes, so ROSC is still not attainable.
So we'll call the gynecology on call. We'll stop here. We'll take the patient to labor room.
We will continue the CPR and we will take the patient for perimortem cesarean section.
Okay. So we have We'll stop here. We'll continue back after cesarean. Now, can we restart the scenario? Patient has come back after cesarean session. Patient like cesarean was done. Now we have to manage the patient again. Okay. Now the problem currently persisting is her BP is still very high. We had given magnesium sulfate. She has developed cardiac arrest during magnesium sulfate. Maybe her creatinine was very high. We don't know, SLE patient creatinine was heavy. Then cesarean was done. Now that problem is settled. Okay. Now the current problem is her BP is very high, 169 by 110. Okay. Now we have to manage that also.
This is an hypertensive emergency situation, so we will go ahead with IV administration of antihypertensives. The ideal agents that are preferred is injection labetalol. So initially we will give injection labetalol 20 mg IV stat we will give, and we will reassess after 15 minutes.
Okay, you can give labetalol.
Injection labetalol 20 mg IV stat given.
We will wait.
Right now we have again reassessed. The BP has come down to 140 bar 90 millimeters of mercury.
So after giving labetalol, BP has come down. We have to continue the infusion and we have to continue the treatment. So what all things we have done? Now we have a patient who is having high BP, history of seizure. She had SLE. She is pregnant. So when there is SLE, there is a high chance for renal failure, eclampsia, all these things. Patient may be on some drugs for pre-eclampsia. We don't know what was the exact drug she was taking. But here we received the patient with seizure. So you had given magnesium sulfate, correct dose, but patient had gone to cardiac arrest. That may be due to?
Either patient might have renal failures.
Okay, renal failure and magnesium toxicity is the most possible reason for a cardiac arrest like this. Okay, there is some other reason also can be there. But we are effectively managed that cardiac arrest with CPR and adrenaline infusion. Then since it is not getting controlled with the ceasing activity or hypertension not getting controlled, we had requested the gynecologist to go for LSCS. Okay, that is done. And after that, the ceasing activity completed, there was no issue, but BP was still high. Okay, then you have to control the BP, otherwise patient, next she will go to pulmonary edema. So you had started labetalol and now BP is well controlled. So we can discuss about the case. How do you manage eclampsia? How do you manage pre-eclampsia? How do you manage hypertension after delivery? These three scenarios are slightly different but almost similar.
In this scenario, like eclampsia, the first step will be stabilizing the airway breathing circulation disability.
Okay.
Second step will be administration of the magnesium sulfate.
Okay.
Third step will be administration of antihypertensives. And final step and the definitive management is termination of the pregnancy.
Okay. So that is a definitive management. Even if you treat the hypertension, patient will not improve. Definitive treatment is always termination of pregnancy. So that was done. So the patient improved. Now the next problem is hypertension persisting after the delivery. So that may not be a simple pre-eclampsia or eclampsia. It is a hypertension in that patient persisting throughout her life. Now it is aggravated because of her pregnancy. Okay, so that has to be aggressively managed than your pre-delivery management. Okay, so here we have started labetalol. Which all drugs can be used in this type of hypertensive emergency urgency?
The first line agents recommended by ACOG guidelines is one is labetalol. If labetalol is contraindicated, then we can think about hydralazine and nifedipine.
Okay.
Hydralazine, initially we will give 5 mg, then we will wait for 20 minutes, then again we will give 10 mg, again wait for 20 minutes, still not residing, again 10 to 15 mg.
So that is IV. IV is not available in India at present. We have 25 milligram tablet. That can be tried. Or like you told, what is the next alternative? Nifedipine. The problem with the nifedipine is nowadays you know that we cannot give sublingual nifedipine. That can crash the patient. So that also has to be given orally. What else? What are the other drugs which can be tried in hypertensive urgencies? What are the other drugs? So we suppose you have this IV hydralazine. That is one of the best drug. There is a vasodilator, arterial dilator. So predominantly arterial dilator. What are the other drugs which can give similar effect without any much complication?
Calcium channel blockers.
That is also which one you want to give? Verapamil, diltiazem. Okay, that can be tried. Then what else? Why not NTG? What is the
NTG.
problem? Is there any problem with NTG?
No, so NTG.
There is no major problem with NTG. You can definitely give NTG. Only thing it can produce some headache or some vascular complication. Otherwise, NTG is one of the safest drug. Okay, including in pregnancy. Whereas SNP is not that safe in pregnancy. You should avoid that. NTG can be started. Okay. How do you control the BP after the delivery? So delivery is over. You had given labetalol every day. We cannot give labetalol. So how do you manage afterwards?
Either we can start the patient on calcium channel blocker, sir.
This patient may have high creatinine, maybe the creatinine value is 3. Because of SLE, she may have a chronic kidney disease. So what all drugs can be selected?
The drugs that to be avoided are ACE inhibitors and ARBs.
So these drugs should be avoided both in renal failure and in pregnancy. AC and ARB should never be used. But you can use any other drug. You can use calcium channel blockers. Which calcium channel blocker you prefer in this patient? She is having renal failure. Which one you prefer?
Verapamil.
The problem with verapamil is it is going to produce already bradycardia. Okay, so these drugs which can produce bradycardia, they are not very safe in renal failure, and you need to give a short-acting drug. So nifedipine is the best short-acting drug among the class. Amlodipine is a very good drug, but what is the duration of action?
24 hours.
It may act for 12 to 24 hours. In renal failure, it can extend. So that's why in most of the renal failure patients, you can see the nephrologist notes. They write nifedipine is the first line choice. If nothing else is there, only they'll go to other drugs. So try to avoid drugs which can produce bradycardia. Try to avoid drugs which are long acting. Okay. So in that class, nifedipine has got all the qualities to start as an antihypertensive in this one. Okay. What other drugs you can give? So nifedipine is a very good drug. The other drugs, routinely you are seeing a lot of patients with renal failure in your emergency room. What are the drugs they normally take?
Aspirin.
Aspirin is given in the pregnancy stage. You can give to prevent pre-eclampsia and eclampsia. In proteinuria, when you are seeing proteinuria itself, you can start aspirin. Arcamin is a very good drug. It can control the BP. Only problem is if you start, there will be some sort of depression. Already patient is pregnant lady. She can have postpartum psychosis. Arcamin may create problem. What are the other drugs? So which was traditionally used in pregnancy? Alpha-methyl dopa. Alpha-dopa is one of the common drugs we use in pregnant ladies. Okay, that can be used. There is no issue. Previously it was the drug of choice, but nowadays everyone use beta blockers. Okay, can we start beta blocker in this patient?
Beta blockers also.
Beta blocker also safe, but only thing again the heart rate. Okay, so what is Brash syndrome? You may be knowing Brash syndrome.
Bradycardia, renal failure, AV nodal block, and hypertension.
So only thing we have to be very careful when we are starting beta blocker. There is a high chance for patient is having renal failure, so the drug can accumulate. Patient itself can have hyperkalemia, so bradycardia can increase. Heart blocks can be produced. That we have to be very careful. That's why if you see most of the patients who is having renal failure, they are on nifedipine, and like she told, Arcamin. Arcamin is a centrally acting drug. Only thing is pregnant ladies you try to avoid because it can also produce some psychological issues. So we try to avoid that. Any other drugs? Other antihypertensive? Calcium channel blockers, beta blockers, alpha blockers. Then diuretics. Can we give diuretics?
Relatively contraindicated, but still we can give diuretics.
Why it is contraindicated? What is the contraindication in pregnancy? Pregnancy it is we don't give this diuretic unless until she is having severe pulmonary edema or something, or renal failure and anuria, or decrease your not, but you can give. But what is the problem in a patient who is having renal failure and diuretic? Is there a problem?
Worsens the renal failure, sir.
That is a theoretical problem. Like you think when you give diuretic, there will be dehydration, and that can produce reduced kidney perfusion. So that is a theoretical problem. In early renal failure, it may be correct, but late phase of renal failure, we give Lasix for every patient. Okay, that doesn't mean that the patient will go to hypovolemia and further deterioration in the renal this one. But we have to have a balance. Like if you give lot of Lasix, patient definitely will go to hypovolemia and renal failure, further renal failure. But small dose may be helpful for all these patients because they can have pulmonary edema, other complication, may be helpful, not definitely. So better drug will be always nifedipine, and like she told, Arcamin can be given, alpha methyl dopa can be given, that also can be continued. Okay, can we discharge this patient now?
Yes, sir. Once the vitals are stable.
So should we give some antibiotic? Cesarean is done.
Ideally not recommended.
It is not recommended. The only thing is she is having SLE, maybe on steroids. That depends on discretion of the treating gynecologist. Otherwise, there is no antibiotics also required. They may give 1 dose of antibiotic before the cesarean. That is more than sufficient. No other issues? We can discharge the patient. Okay, thank you.